we make in the management of breast cancer in young patients. And finally, we are going to address survivorship issues with a special focus on those that are age-related, including fertility and pregnancy. Before starting the session, some housekeeping rules. So for the online audience and also for those of you that don't feel comfortable to go to the microphone, you can submit your question scanning the QR code that you can see in the slides. We're going to have the Q&A session at the end of the 3 presentations. So before starting with the first talk, I wanted to introduce my co-chair, the patient advocate, Nadia Smith from Dallas, Texas. She has a Bachelor of Science in Business Administration and Marketing from Xavier University of Louisiana, an MBA from Jackson State University, works for KPMG as a Global Technology Program Management Consultant. She was in the best shape of her life when she was diagnosed with early-stage breast cancer at the age of 33 back in 2016. She has evolved from simply surviving to thriving as a breast cancer advocate, promoting awareness through speaking engagement, social media, radio, and television broadcast. She's involved with various organizations and initiatives such as the AACR, Susan G. Komen, and others. Nadia strives to use her voice to bring awareness to a disease impacting women of color at disproportionate rates, to stand in the gap for young women diagnosed under the age of 40 years. She shares her story to encourage and give others hope that there is life after diagnosis, so much that at 7 years after diagnosis, at 40 years old, Nadia just welcomed a miracle baby boy on February 10, 2023. And please join me in welcoming Nadia. We're going to start with the first talk on biology of breast cancer in young women by Professor Camila dos Santos. She's Associate Professor and Associate Director of Diversity, Equity, and Inclusion at Cold Spring Harbor Laboratory in New York. Originally from Brazil, Professor dos Santos has dedicated her research at Cold Spring Harbor Laboratory to uncovering breast cancer risk modifiers. Her team has not only identified risk modifiers, but has also engineered a series of mouse models in which pregnancy demonstrates the potential to inhibit mammary tumor development. The Dos Santos group is now elucidating the intricate interplay between direct and indirect contributors to breast cancer risk, particularly in response to the physiological challenges inherent in the young female body. For her research in normal breast development and breast cancer, she has been granted a series of prestigious awards, including the AACR Breast Cancer Foundation Young Investigator Award and the Breast Cancer Research Foundation Award. Welcome.
All right, everybody can hear me? Thank you so much for the organizers for this incredible opportunity to share the work that we do in the lab, to study how change to whole physiology in the body, especially in young age, reproductive age, change not only breast development, but also change cancer risk. And, okay, there you go. I have no conflicts to disclose. So again, as I mentioned, my lab is very interested to understand the effects that alterations to women's health has on mammary gland development and the cancer of breast risk. And we focus on understanding all the stages of development of the breast, so then we can understand how the tissue works, and then we can understand how one can define cancer risk. As you can see from this slide here, the major steps of highly activated cell division stages of mammary gland development are heavily influenced by the presence of hormones, whereas the absence of hormones, either early during development or later in life, actually stop the cells from growing and dividing. And we have been, for the past 10 years, developing models that we can mimic those differences in the differentiation of the breast, not only using organoid models, but also animal models, and how, with a focus on how response to hormones actually change the transcriptional, the gene expression that controls cellular behaviors, but also looking at what happens at chromatin, the epigenomic landscape of those changes. So pregnancy changed the normal breast, two pregnancies here. So there are a lot of changes to the normal breast during pregnancy. So I mentioned to you cellular divisions, and here we can mimic that in a model system, either with a pseudo-pregnancy in which we give the animals just the pregnancy hormones, or with a true pregnancy. And what I'm showing here is that there's expansion of cells, but also we started producing of milk proteins. But pregnancy does not only change the ability of the cells to grow. There are a lot of changes that are happening in epithelial cells of the breast that are important for breast epithelial cells to develop and to produce milk. What I'm showing here is a collagen staining with second harmonic microscopy. It's in those gray lines here. And here I'm quantifying that pregnancy itself not only changes the composition of collagen, the position that you have in the mammary gland, but also changes the alignment. So it goes beyond epithelial cells alone. Change, as I mentioned before, the changes that are happening in response to hormones change the cellular fates and state. What I'm showing here is a UMAP of a single-cell RNA-seq analysis that showed that cells that were sitting here in response to pregnancy hormones, now they assume a different disposition on the graph, suggesting that even though they may have the same cellular identity, they express different genes, therefore suggesting a different state. But those changes to expression are not only occurring during pregnancy. We know that many of those changes remain altered post-pregnancy. Here I'm highlighting several studies from the past several years showing that both epithelial cells from animals, rodents, mouse and rats, or humans, they have a different transcription output after pregnancy, suggesting us that our changes that are occurring during pregnancy are stable and is stably changing, permanently changing the fate of epithelial cells. This is exactly how I started my group. So we first asked the question, what epigenomic changes are associated with this change in transcription? We showed that pregnancy-induced loss of DNA methylation at very specific regions in the genome. That loss of DNA methylation during pregnancy is labeling genes that are responsible for milk production and cellular growth. And they are marking regions in the genome where transcription factors have to come back faster in a second pregnancy. And those regions of loss of DNA methylation are also then gain H3K27 acetylation, which is a mark of active transcription. And with that, we established that the first pregnancy cycle leaves an epigenetic memory on breast epithelial cells, so they know how to resume milk production much earlier on the second pregnancy. Change to transcription and epigenome are not the only ones that we see after pregnancy. We now have expanded that to understand how pregnancy changes the tissue of models that are predisposed to develop breast cancer. In this case here, we have animals that never been pregnant, BRCA knockout animals that have gone through pregnancy, and this is again a single-cell plot that shows that epithelial cells that were sitting in one position of those plots, now they either disappear or they're changed with pregnancy, suggesting that those changes are sustained for a long time, stably change the mammary gland. Not only epithelial cells are altered, we see alteration to the immunity of the breast after pregnancy. What I'm showing here is flow cytometry analysis of an unconventional type of T cells that we see that infiltrate the breast after pregnancy. They remain there long after pregnancy is gone. And they, again, illustrating that those changes that are brought to normal breast tissue go beyond epithelial cells. It was very satisfying to see in a recently published Human Normal Breast Atlas that we're going to hear more from on Friday, also identify changes to the state of epithelial cells and to the immune composition of breast cells, really showing here that our modeling systems have similarities with what is happening in the breast of women. Why I'm talking to you about pregnancy? It's because young women and the risk of breast cancer has risen in the last 10 years. And here, young women, I'm defining by women that are still at the reproductive age. Young women will develop harder to treat cancers. The mortality in response to treatment, it is increased. There's a great predisposition showing here for women that 25 plus years that's predicted by this year. And what my lab has been developed so far are modeling systems that not only study pregnancy, but the combination of other effects that happens in the body of a woman at that age to understand if those, together with pregnancy, are modulating the risk of cancer. Why we are studying pregnancy and breast cancer? In the early 1700s, it was the first time that the idea that parity changed the risk of breast cancer was made, but we know now that this is much more complicated. Women at all age after pregnancy, they have a moderate and transient risk to develop breast cancer. This is called postpartum breast cancer. But what we are most interested to understand is how women that are pregnant at the age of 20 years old, they have a marked decrease in the risk of developing breast cancer, 30 to 40%, depending on the subtype and the mutations that you're talking about. And that decrease in the risk sustains at postmenopausal age. Now, many groups have studied, developed models that can in a laboratory setting mimic those phenomena they can understand. We are very interested to understand the effect of pregnancy breast cancer in BRCA mutations. Why that? Because I just told you that pregnancy and breast cancer are confusing, so is the relationship with BRCA1 mutations. So in a study published in 2026, there was demonstration of a correlation between parity and decreased breast cancer risk for both patients that have BRCA1 and BRCA2 mutations. Now, in the study that it was published in 2018, that was not quite the consensus, in which only women that had 4 pregnancies were now protected from developing breast cancer, which suggests to me that if a woman engaged in a study after 4 children, they probably started having children very early on. So what we have been doing is to develop mouse models in which we can isolate the effects of early pregnancy, the transient effects of a postpartum, and the menopausal effects of cancer risk to understand what has to do with prevention that then we can learn and manipulate across all those other models. So we developed 2 models in which we can mimic an early age of pregnancy and decrease breast cancer risk. In the first model here, we use a MYC overexpression system. We use MYC because MYC networks are one of the top upregulated networks that happen in BRCA1 mutant breast cancers. And using this system, we showed that never pregnant animals develop the equivalent to ductal invasive carcinoma, but animals that have been going through pregnancy early on in their life have a largely normal memory tissue. We then tested the question using a BRCA1 loss of function animal with 1 copy of p53 loss. And in this model, pregnancy inhibited the development of memory tumors by 80%. Suggesting here that we have 2 models and that we can move forward to understand the risk of cancer under the perspective of pregnancy. Using these 2 models, we made observation that MYC now binds to different regions in the genome, and when it's bound to different regions in the genome, now activates senescence of those epithelial cells that then undergo autophagy and phagocytosis by the system, and therefore that's one of the reasons why in this model, after pregnancy, epithelial cells do not engage into a neoplastic transformation. We also showed that during the infiltration of those unconventional T cells that I just presented to you a little while ago, it's very important for tumors to be inhibited in a context. We can use mouse models in which they lack these immune cell types, and in this case, they will develop memory tumors independent of pregnancy. We can then also target specific factors that control senescence in epithelial cells, and in this case, too, epithelial cells will develop into preneoplastic cells independent of pregnancy. And here, just to summarize what we did so far, we showed that pregnancy-induced epigenetic change not only change how epithelial cells regulate gene expression, but those changes in regulating gene expression are actually influencing the communication with the immune system, which now presents to us an opportunity which we are moving forward is how we can now harness changes to immunity to develop preclinical models of preventive treatments in a laboratory setting. But early age of pregnancy does not fully prevent cancer development. So about 60% of women that have early age of pregnancy would still develop breast cancer. So, and as we develop a model that now we can mimic early age of pregnancy, we have now applying those models to understand other parts of how pregnancy induces cancer risk, such as gestational breast cancer is a rare form of cancer that targets women at a young age as well, very hard to diagnose, very hard to treat, and we think that with our modeling systems, we can improve not only on diagnostics and detection, but treatment as well. And also understanding this peri to menopausal transition. We talk about risk of cancer at menopausal age, but we know that change that precede menopausal are very drastic with up and down of hormones and an array of different symptoms that I can explain to you later on if you want to. But we now plan on combining perimenopausal transition to early age of pregnancy to understand what does it change with tumors development, if tumors still develop, what is that perimenopause is changing from an early age of pregnancy. All of those models here are using the influence of hormones, pregnancy hormones, estrogen into cancer development. And that got us to think about other non-hormonal changes that could be going through, happening to women and could also influence the risk of breast cancer. And the one that I'm going to share with you here today is how the influence of a systemic response to urinary tract infections, or UTIs, as I will be referring to the rest of the talk, can develop mammary gland, can influence mammary gland development. Why UTIs? So as breast cancer, UTI, risk factor for UTIs is age. In this case here, younger women are presented with UTI more often than older women. And pregnancy itself can increase the incidence of UTIs just because of a hormonal and anatomy changes. 1 in 5 women will develop at least one UTI-like disease throughout their lifetime. 2 of those women will remain asymptomatic. The body will heal the infection. 2 other women would need the intervention of antibiotics, and with the first set of antibiotics, they will clear the disease. But 1 woman would require a very heavy intervention of antibiotics to clear that disease. To develop a model like that, we utilize uropathogenic bacteria E. coli that we can directly inject into the urethra. The bacteria will now attach to the wall of the bladder, develop as a UTI, is a self-healing system. Animals are sick for about 10 days with a UTI, meaning that we can detect bacteria in their urine, but then after that, the body fights the bacteria, and then they become UTI-free. We can treat those animals with broad-spectrum antibiotics as well, and in this case, UTI goes away. And what we found with this model is that histological signs of cystitis and venous scarring are present, so mimicking what we see in women. There's no bacteria in the blood or in the mammary gland. So this is a model of local infection. Bacteria is not circulating in the body or migrating to the breast. And the most striking phenotype that we notice that happens that UTI-bearing animals have an increased collagen deposition of the breast, showing here in trichrome blue, in the blue area here. And this is quantified here. We can treat those animals with antibiotics, and now collagen goes back to normal. And we published this early this year, and to summarize everything that we've done so far from a wild-type normal mammary gland development, we discovered that UTI-bearing mice, they have increased collagen accumulation, increased neutrophil abundance in the mammary gland. This is not exclusive to the mammary gland. We see neutrophil in every single organ that we look at. Collagen accumulation is specific to the breast. We look at many other tissues. We could not see accumulation of collagen in other breast tissues. There's increased adipogenesis, and the change that we see here in the collagen are actually inducing YAP-dependent transcription in epithelial. Epithelial is expanding, the ducts are becoming hyperplastic. How can a UTI induce change to the mammary tissue? So UTI induces systemic host responses. So the first thing that we look at are changes to the plasma of those animals, and the answer was yes. And the factor that causes the attention the most was TIMP1. TIMP1 is a metalloprotease inhibitor. It associates with MMPs in the tissues, and by this association prevents the ability to remodel collagen. They can also associate with integrins at the surface of the epithelial, the surface of epithelial cells, and activate anti-apoptotic pathways in the cell. We see that TIMP1 is markedly increased in animals with UTI. We treat them with TMS. It goes back to normal levels. So the question that we ask, can we target TIMP1 and would that revert the symptoms that an animal have with a UTI? So we develop a model in which we can give mice anti-TIMP1 neutralizing antibody. They're fine, there's no body weight loss here. And as you probably expect that I'm gonna tell you, is that TIMP1 neutralizing antibody treatment revert the collagen accumulation that we see in animals with UTI. They're still having a UTI. You still detect bacteria in their urine, but now their mammary glands go back to normal, and we also see a reduction in the ductal size, suggesting that it reduces tissue hyperplasia. Is there a correlation between UTI and breast cancer? So Stephen Lewis, an MD PhD student in the lab, he went into the GeneBase UK Biobank and asked what other comorbidities are associated with BRCA1 mutations. And to our surprise, he saw that some of those diseases were associated with genital urinary infections diseases, which we use that as a motivation to now to test, can a UTI change the tumor progression in animals that are predisposed already to develop memory tumors? And again, we use our BRCA1 loss of function model in which we can time the development of tumors, and they resemble cellular similarities with BRCA1 mutant we see in triple-negative breast cancer patients. 2 weeks post-infection, so the animals are subsidizing the disease. We see that it's collagen increase in the memory tissue of BRCA1 knockout mouse. There's increase in the duct counts. There's increase in the adipogenesis and the increase in spheroid forming in size. So suggesting that similar to wild type, UTI is inducing change to the BRCA model. Now we can harvest the tissues here. At this time, there's no tumor, and you see those organoids growing faster, suggesting that there's activation of growth processes that a UTI is, the response to UTI is inducing to those tumors, to those tissues, to those cells. We then allow to monitor tumor, and what we saw that the UTIs decrease the onset of memory tumorigenesis. So here the tumors in BRCA knockout UTI mice develop much sooner than the ones that are the control PBS or the ones that are treated with TMS, suggesting that the change that the UTI is inducing the memory gland can exacerbate tumor development. At the end point, those tumors are the same size and they have the same histopathology, at least by the analysis that we've done so far. We went at this point here in which we see tissue hyperplasia 2 weeks post-infection, and we ask, what are the cellular changes that UTI is inducing here? And we did single-cell RNA-seq analysis here. So what I'm showing here is that, so here we have our luminal progenitor cells, basal cells, and hormone-sensing cells. And one of the things that we notice is in a UTI mouse model, there's expansion of this blue cell type, which you call it to be BL cells, because those cells express not only keratin 8 and 18 as luminal cells should express, but they also express keratin 5, which is a mark of a basal cell type. And we were quite intrigued by that because John Brugge many years ago suggested that the root of cancer development in BRCA1 mutant patients are those cells that acquire both luminal and basal identity. We validated doing that IF, and we can see here, again, just to reiterate, this is at a time point where there's no tumors yet. We see increase of those basal luminal cells in the breast. We then look back at our single cell again. There's YAP-activated systems, but there's one of the genes that we didn't see in the wild type with integrin beta-6. Integrin beta-6 is mostly abundantly expressed in BL cells in a UTI mouse model, which allows us now to monitor the expansion of those cells without using single-cell RNA-seq. This is a bit complicated, so I'm going to take my time to explain here. In shades of blue, we have integrin beta-6 positive cells from our PBS control animals. And what we're showing here that those cells increase in numbers as the animals age, and they are getting close to the time they should be developing tumors. The shades of red in here are integrin beta-6 positive cells from animals that have UTI. So they are already at a higher levels, and they remain at the time increase until the development of the tumor. What are integrin beta-6? They sit at the surface of cells in response to either change to the ECM or to secreted factors that are secreted by the stromal that can activate a myriad of programs in the cell, including epithelial to mesenchymal transition and angiogenesis. There are many ligands that can activate integrin beta-6. Some of them could be perceived as collagen with staining. So Steven did a bunch of stainings, and he actually identified that tenascin C is the collagen fiber that component that is most expressed, abundant in the mammary glands of BRCA1 knockout UTI animals, just linking changes to specific types of ECMs to those that actually activate integrin beta-6. We then ask the question, is integrin beta-6 the bad guy here that is changing, inducing change to the memory tissue of UTI mouse? We gave them neutralizing antibodies against integrin beta-6. We can reduce ductal counts in UTI-bearing mice, but we cannot decrease the collagen accumulation. Really suggesting here that the collagen is the key change that is being induced by UTI, and that's perhaps what we should be looking at in terms of what is changing to the cancer development here. We did a plasma cytokine array again. We saw that TIMP1 was upregulated here too. We also see CXCL13 here as well. We ask which one of those are actually the most important for collagen accumulation. So we treated animals with recombinant protein, and only animals that receive recombinant TIMP1 have an increase in collagen deposition. The ones that increase CXCL13 do not. And I can elaborate what we think that this is up if questions come. We then apply our TIMP1 antibody neutralizing treatment into BRCA1 animals that had UTIs. And TIMP1 targeting here decreases collagen accumulation in UTI-bearing animals that are BRCA1 knockout. It also decreased tenascin accumulation, and most importantly, it draws back the tumor development to what it was to much longer late onset of tumor development. So what I showed to you today is that in UTI-bearing mice, at least wild type, there are changes to the ECM, immunity, adipocytes, and ductal size that are induced by UTI. In a BRCA1 knockout mouse, we don't see expansion of neutrophils in the tissue, but we do see increased accumulation of collagen, adipogenesis, and YAP-dependent transcription. More specifically, YAP-dependent transcription and collagen in the BRCA knockout are then being remodeled by TIMP1 levels that then are leading to the upper expression of integrin beta-6 at the surface of very specific subtypes of epithelial cell. Not all cells are having that gain of expression, and that is speaking to the tenascin, which is at part of the collagen deposition here. This leads to an early onset of memory tumorigenesis, and then we can target every single one of those pathways if we treat BRCA1 knockout animals with a TIMP1 neutralizing antibody. I wanted to acknowledge everyone in my lab that has supported the development experiment, specifically Steve Lewis, that he's here in the audience, at least I hope so, for doing most of this work, and Sarah Tovar, a very incredible and talented high school student that we have in the lab. I wanted to acknowledge collaborators and our lab funding, and I look forward to your questions at the end of the session. Thank you very much. I don't know what else I need to do here.
Our second speaker today is Professor Prue Francis. She's a breast medical oncologist, clinician researcher, co-lead of the breast medical oncology at Peter Mac Cancer Center in Melbourne, Australia. She undertook a medical oncology fellowship at Memorial Sloan Kettering in New York and then returned to Australia. Prue is a member of the Scientific Advisory Committee of Breast Cancer Trials Australia and New Zealand and IBCSG cooperative groups. She's a member of the St. Gallen Early Breast Cancer Expert Consensus Panel, the Advanced Breast Cancer International Consensus Panel, and the Steering Committee for EBCT-CG. She chaired the steering committee for the premenopausal soft and text adjuvant endocrine trial, so she's definitely the right person to discuss on ovarian suppression. Thank you.
Thank you very much, Matteo. I was reflecting that it's actually 10 years ago that we had the opportunity to present the very first results from the soft trial here. So it's really nice to have the opportunity to give you some reflections on the things that we've learned since that time. How do we progress this one? This one? Have to go. Okay. This is my disclosure. So in terms of the types of ovarian function suppression, we've really got a couple of main alternatives in early breast cancer. Reversible method by injections with a GnRH agonist, and this is most appropriate in young women for whom we may not want a permanent menopause. And then for women who are closer to the natural age of menopause, a surgical menopause via a bilateral laparoscopic approach may be a preferable choice for that woman to avoid having to attend for long-term regular injections. And while radiation can cause permanent ovarian ablation, it's not a preferred method for early breast cancer. So what about in the future? So GnRH antagonists, for example, Dugarelix, this has actually been tested in the neoadjuvant setting with letrozole by the IBCSG in a randomized phase 2 trial, and it did achieve faster ovarian function suppression, and it also seemed to be more effectively maintained than with a GnRH agonist with letrozole. However, we don't have other breast cancer data apart from this one study. What would be really nice would be to have an oral option, which I'm sure would be preferred by patients. But to date, we do have oral GnRH antagonists, for example, Elagolix. But this is not yet approved for breast cancer, although there are case reports of use in cases of patients who had incomplete estradiol suppression on a GnRH agonist. So how often do we need to give this treatment? So the standard treatment in breast cancer really for a long time has been 4 weeks, and this is typically approved in most countries. The 3-monthly long-acting GnRH agonist is approved for breast cancer in many countries, but not in all countries. And I think we have more data for the 3-monthly injections with tamoxifen than with aromatase inhibitors. However, the 3-monthly GnRH use of goserelin has now been included in the NCCN guidelines this year, and also 3-monthly administration has been permitted in the large planned offset trial, which has started accrual in premenopausal women, which is using an aromatase inhibitor. So what about estradiol level monitoring? Is this required if we're trying to suppress the ovaries in young women? And I think this is a controversial question. I don't know that there's a right answer. When we conducted the SOFT and the TEXT trials, there was no routine monitoring of these levels built into the trials. In my personal practice, I'm not routinely testing this. However, if there is any reduction or if there is an absence of vasomotor symptoms, or if my patients report any spotting or bleeding after the initial few weeks of suppression, or if there are any other symptoms that the patient notes suggesting a menstrual cycle, then I do test levels. In our soft test sub-study, it was evident from centralised testing of estradiol levels that there were some women that did not obtain persistently the very ultra-low levels that you would expect perhaps in a postmenopausal woman on an aromatase inhibitor. And this risk of not having a persistently ultra-low level seemed higher if the woman had not had chemotherapy or if the body mass index was high. Perhaps it will be more risky if a woman is very young. In terms of assaying, it's not straightforward if you want to test estradiol levels. In many of our routine labs, we have different assays. The gold standard assay is the LC-MS assay. And it's fair to say that if you have other assays that you're using rather than this gold standard, that there are some drugs that we might use in breast cancer that can actually cross-react in the assay and cause confusion, including exemestane, abemaciclib, and fulvestrant. So who should get ovarian function suppression? Now, on the next 2 slides, I'm going to list 8 categories of patients that I'm going to discuss in my talk. But just to show you, women who are not at low risk for recurrence, very young women, premenopausal women who you're thinking of an aromatase inhibitor, women who have chemotherapy-induced amenorrhea, who you are thinking of for an aromatase inhibitor, especially under the age of 50, premenopausal women planned for adjuvant ribociclib, Premenopausal women with either estrogen receptor negative or estrogen receptor positive breast cancer who are planned for chemotherapy and have not completed childbearing. Now, a category most people will tend to forget is premenopausal women with ER-negative early breast cancer who are planned for chemotherapy and have completed childbearing. And then finally, I'm going to just briefly discuss premenopausal luminal breast cancers that appear to have a favourable type of biology. Can we use ovarian suppression as an alternative to chemotherapy? So the first category of patients, premenopausal women who are not with estrogen receptor positive breast cancer that's not at low risk for recurrence. And I want to remind you that in the SOFT and the TEXT trials, the tumours needed to have, the women's cancers needed to have at least 10% of cells showing some hormone receptor staining, so it was not those low levels. And both ASCO and ESMO have guidelines that give an indication of the sorts of patients who should be considered for ovarian function suppression. I want to remind you of the design of the SOFT trial. The SOFT trial was testing 3 adjuvant endocrine therapy regimens, tamoxifen for 5 years being the control arm, and the primary comparison was the addition of 5 years of ovarian suppression to tamoxifen, but we were also looking at an aromatase inhibitor exemestane with ovarian suppression. There were 2 categories of patient who could enter the trial according to the stratification of prior chemotherapy or not. And this was by choice of the doctor and the patient whether they received chemotherapy. But if they received chemotherapy, they needed to demonstrate a premenopausal estradiol level within 8 months to be eligible for the trial. Now we have the 12-year results that have been published last year, and we can see on the bottom of these 3 curves, the grey or the grey line is the tamoxifen alone arm, and then above that, the red line, tamoxifen plus ovarian suppression, and on top, the aromatase inhibitor, exemestane plus ovarian suppression. And this is showing disease-free survival at 12 years. So by intensifying the endocrine therapy, we can in fact improve our disease-free survival at 12 years. Now I want to drill down on a subgroup, because I told you that many patients in the SOFT trial did not have prior chemotherapy. So now I'm drilling down on a subgroup who entered the trial after prior chemotherapy. So they were necessarily a younger cohort of patients because they needed to show their ovaries were still working after the chemotherapy. And I'm showing you those with HER2-negative tumours. And here I'm showing you overall survival at 12 years. And again, you can see an incremental improvement as the endocrine therapy is intensified with the use of ovarian suppression, either with tamoxifen with the red curve or the aromatase inhibitor with the blue curve. But here are these other women who had lower risk breast cancers. This was the no chemotherapy cohort in SOFT, median age of 46. And what you can see is that all the 3 curves are pretty much on top of each other. So there are very few distant recurrences and very few deaths from breast cancer in this cohort, with over 95% of these women alive at 12 years without ovarian function suppression. So there are clearly premenopausal women that can do well without chemotherapy and with tamoxifen alone. So who are the patients who what sort of clinical and pathologic features would you want to see before you could decide that tamoxifen alone would be good? And here are the features that I'd be looking for. And I think age is an important one, because when we look at the SOFT no chemotherapy cohort, 90% of that cohort were at least 40 years of age or older. We also want the tumours to be HER2 negative, node negative, T1, low to intermediate grade. We want to see good progesterone receptor staining. And you can see some other features there, the low key 67. And if you were doing a recurrence score, we would also want that to be at the lower range. So now thinking about the very young women with estrogen receptor positive, HER2 negative breast cancers. Now, young age, this is showing you women who were either in the SOFT or the TEXT trial, and they had hormone receptor positive, HER2 negative cancer, and showing you distant recurrence at 8 years, and just showing you broken down by the age at entry on the trial. And if you can't see all the curves easily, the purple line at the bottom and the red one next above that, those are the younger women under the age of 40. So young age in these trials was a risk for distant recurrence. Last year at ASCO, the Early Breast Cancer Trialists Collaborative Group presented their meta-analysis looking at patients who were randomised to receive ovarian ablation or suppression or not. And they basically divided women in these trials, and this is showing you the data in women who either had no chemotherapy or were shown to be premenopausal after their chemotherapy. And what you can see here is there appears to be a larger absolute benefit from the ovarian suppression in those under the age of 45 than in those who were aged 45 to 54, but were still premenopausal. What about in the SOFT trial? In the SOFT trial, I believe from the results that we should strongly consider ovarian suppression in women under the age of 35. And when we look at this age group in SOFT, more than 90% actually had received prior chemotherapy before being randomised in the trial. If we look in the SOFT trial at 12 years, for those who were randomised assigned to tamoxifen alone, nearly 1 in 2 had had a further invasive breast cancer event of some type if they did not get assigned to ovarian suppression. And in terms of survival, 1 in 3 of those assigned to tamoxifen alone without ovarian suppression had died. And we see a meaningful overall survival improvement with the ovarian suppression arms in SOFT at 12 years in this cohort of under 35 patients who have ER-positive, HER2-negative tumours. Adjuvant endocrine therapy and non-adherence is common, and it's particularly common in young patients. I'm showing you here some percentages of patients who did not continue to adhere to their ovarian suppression that they were assigned in the SOFT trial. And you can see it increased over time, and it's understandable. There are many reasons for toxicity, for pregnancy, and other reasons, turning up for injections every 4 weeks for years. You can understand this. Certainly side effects are a common cause, and interventions might help, but actually not adhering to endocrine therapy has been shown to increase your risk of recurrence. And there was very interesting French data that was presented at ESMO this year. They had a national cohort, and they were looking at, here on this slide, I'm just showing you young patients, very young patients, and looking at the difference in outcome for those who had strict persistence with their endocrine therapy with no 30-day break, as compared to those who did have these longer breaks from their therapy, and they could see actually a 5.6% difference in their outcomes if they were completely adhering versus not able to adhere. So I think their adherence does matter. Okay, now looking at some other categories of women, if you have a premenopausal patient and you want to give an aromatase inhibitor, we know that aromatase inhibitors are really only effective if you give concurrent ovarian suppression in a premenopausal woman. Now, why would we actually want to give an aromatase inhibitor with ovarian suppression? Now, I'm just going to show you here the text trial above and the SOFT trial below, and there were 2 common arms in these trials that we analysed together, which were the comparison of the ovarian suppression with the different oral agents. So why would you want to give ovarian suppression with an aromatase inhibitor? When we look at the patients in SOFT and TEXT who actually received chemotherapy, which was optional according to their risk features, the patients who had received chemotherapy or did receive chemotherapy had higher risk clinical and pathologic features, and they also had a higher risk of recurrence. And when we look at the HER2-negative chemotherapy cohorts in both SOFT and TEXT, we saw improved overall survival if the patients were assigned aromatase inhibitor therapy with exemestane with the ovarian suppression versus tamoxifen and ovarian suppression. And here I'm showing you the 12-year overall survival. On one side, the SOFT trial, the prior chemotherapy, and on the other side, the TEXT trial, all HER2-negative tumours. And with both trials, we got identical results. There was a 3.3% improvement in overall survival with the aromatase inhibitor as the oral endocrine therapy partner. And that 3.3% might be even a little higher if you look at some other high-risk features, for example, large tumour size. You can see here 4.5% absolute improvement in survival at 12 years, grade 3 tumours, it's over 5% improvement in overall survival in absolute terms. And there is an app that Meredith Regan, a trial statistician from the IBCSG, developed. And if you want to go and have a look at that, if you're not aware of it, you can put in different adjuvant endocrine therapy options and clinical pathologic features and get an idea of how the outcomes might vary. So what about if you have a premenopausal patient who you give chemotherapy to, they develop amenorrhea, and you want to give an aromatase inhibitor because of the data I've shown, but they're still, perhaps under the age of 50. I would argue that these patients need to be considered for ovarian suppression, and that's because there is a risk of reversal of chemotherapy-induced menopause when you commence an aromatase inhibitor, and this is really important. And the consequence of this is there is a risk of giving an ineffective oral endocrine therapy. And in fact, there's also been unexpected pregnancies in women in their late 40s who were started on this chemotherapy-induced amenorrhea and then an aromatase inhibitor. So this is an important point to remember. And here was one prospective cohort where they looked at women who had had chemotherapy-induced amenorrhea for more than 2 years and a postmenopausal estradiol level, and they were switched over from tamoxifen to exemestane, median age of 48, and most of them had had long-course chemotherapy, and in fact 30% had recovery of their ovarian function when they switched to an aromatase inhibitor, and it was more frequent in those under the age of 48. So I think you really need to be careful in these younger women with chemo-induced amenorrhea, and particularly if you're giving a short-course chemotherapy regimen. So another category of women who will need ovarian suppression is if you're planning for adjuvant ribociclib. We know that this has actually been FDA approved this year, and I want to remind you in the NATALY trial that adjuvant ribociclib actually required the patients to receive a non-steroidal aromatase inhibitor, so either letrozole or anastrozole, and in premenopausal women they needed to receive concurrent GnRH agonist therapy. Also men did too. And the reason was that tamoxifen plus ribociclib can affect the QTc interval, and so it was not permitted in the adjuvant NATALY trial. So if you're giving adjuvant ribociclib, the ribociclib was for 3 years in the NATALY trial, so there needs to be at least 3 years of the non-steroidal aromatase inhibitor and goserelin. And in the NATALY trial, if the woman needed to switch over to tamoxifen because of poor tolerance, then the ribociclib needed to be ceased. What about abemaciclib? So in the Monarch E trial with adjuvant abemaciclib, they were not all required to receive ovarian suppression with an aromatase inhibitor. You could choose the endocrine therapy, and abemaciclib was for 2 years. But I would point out to you that abemaciclib added to endocrine therapy does increase the risk of venous thromboembolism somewhat. And when they looked at Monarch E in the premenopausal patients, according to the oral endocrine therapy that they got, that it was a lower risk if you were getting an aromatase inhibitor, presumably with ovarian function suppression, than if you were getting tamoxifen. So that might be another reason to think about the aromatase inhibitor with ovarian suppression if you're considering abemaciclib. So what about women who have not completed childbearing? Why would we give ovarian suppression here? And that's to increase the prospects for future pregnancy. Now, we would commence this after completion of other fertility procedures such as oocyte collection, and ideally we'd commence it at least a week before chemotherapy and continue during the chemotherapy. And I draw your attention to the POEMS trial, which was actually studying this in hormone receptor negative breast cancer and showing you that the women who were getting cyclophosphamide-containing chemotherapy and were randomized to get goserelin or not, starting prior and during their chemotherapy. And here I'm showing you that the cumulative prospects of having a future pregnancy were higher in those women in the red curve who received the goserelin with their chemotherapy. And here's a meta-analysis by my co-chair here showing that post-treatment pregnancies in a number of trials are more likely if the women were in a randomized trial where they were assigned to receive a GnRH agonist during their breast cancer chemotherapy. So this should not be the only maneuver offered, but it should be offered. So what about if we look at ovarian fertility protection? Is this a safe thing to do if you have estrogen receptor positive breast cancer, giving this ovarian suppression concurrent with chemo? And the meta-analysis would suggest that it does appear to be safe in estrogen receptor positive breast cancer. When do we start the ovarian suppression? So if the childbearing is not completed, as I've mentioned, we should start the ovarian suppression before the chemotherapy, and then you can start the oral endocrine therapy after the chemotherapy. If childbearing is completed, you may choose to start ovarian suppression after chemotherapy, but it's definitely required with the aromatase inhibitor. And if you're thinking you want to give tamoxifen, you might decide to wait and see in a patient with chemotherapy-induced amenorrhea whether their ovaries recover. Ovarian suppression timing might relate to a number of factors such as childbearing plans, the age of the patient, the planned oral endocrine therapy, and whether there's neoadjuvant or adjuvant chemotherapy. If childbearing has been completed, I think you can either start the ovarian suppression after chemotherapy, as in the SOFT trial, or concurrent with chemotherapy, as in the TEX trial. And we did publish an analysis that was suggested that either approach seemed to give a similar outcome, allowing for the fact that this was not a randomised comparison. If you're giving neoadjuvant chemotherapy, perhaps giving concurrent ovarian function suppression might improve the response. Now, this group is the group that is often forgotten, so I want to remind you about them, because they have estrogen receptor negative breast cancer. And so this is a group where we don't intuitively think of ovarian suppression. So if you have a premenopausal patient with estrogen receptor negative breast cancer planned for chemotherapy and has completed childbearing, what is the chance you're going to remember this? But it is an important group. And why would you do this? You would do this to reduce the risk of premature menopause, as there's no cancer benefit from menopause in estrogen receptor negative cancer, and there are adverse health effects. So we would start the GnRH agonist prior to and continue it just for the duration of the chemotherapy and then stop it. And this is a meta-analysis of GnRH agonist given during breast cancer chemotherapy, just looking at the outcomes according to premature ovarian insufficiency. And I'm not sure if you can see the estrogen receptor status on the forest plot, but estrogen receptor negative and estrogen receptor positive, you can prevent ovarian premature insufficiency on average in these trials by giving the GnRH agonist. And why do we want this? Because these women could have a better future quality of life, including better sexual function. And there's also literature from the non-breast cancer literature to show that permanent premature menopause without HRT in the non-breast cancer scenario has a variety of adverse health effects, including mortality. One last group that I want to talk about are premenopausal patients who have favourable luminal A-like biology. Could ovarian suppression be an alternative to chemotherapy? Now, there's been a number of randomised trials, the TAILOR-X, the MIND-ACT and the RxPonder, and in these trials, mostly the premenopausal women actually got tamoxifen. There weren't many that got ovarian suppression. And there has been the concern raised by these trials that premenopausal women perhaps don't have the same outcomes as postmenopausal women, particularly when the recurrence score is a bit higher or if the women have positive lymph nodes. So why would we want to think about giving ovarian suppression as an alternative to chemotherapy? Have we got any data to say that this is reasonable? Have we got data to say you could do it in a stage 2A disease, for example, in a T2 tumour or a node-positive tumour? I want to show you some data from the TEX trial, and this is the cohort in TEX where patients received no chemotherapy, but they all received ovarian function suppression with either an oral tamoxifen or oral aromatase inhibitor. And I'm showing you here distant recurrence, freedom from distant recurrence at 8 years. And what you can see, if you can see it, circled in blue, are the node-positive patients. 21% of these were node-positive, 19% had T2 tumours, and they had a distant recurrence freedom which was greater than 90%. So there are some patients chosen with favourable biologic characteristics who can be treated with a chemotherapy-free approach. And the OFFSET trial, which has been launched in America, is actually trying to look at some of these issues, but also using an oncotype DX assay. And in Europe, there is another trial as well, the OPTIMA-Young. So how long should we go for? 5 years in soft and text. The ASTRA trial was 2 years. If you give a surgical method, it's permanent. You need it as long as the ovaries are still working. 3 years if you're giving ribociclib. But we lack adequate data on this question. In the positive trial, they actually interrupted endocrine therapy after 1.5 to 2.5 years with a plan to recommence. The ASTRA trial added 2 years of ovarian suppression to tamoxifen for 5 years in women who regained or had persisting ovarian function, and they actually had some improvement in disease-free survival also. So you can benefit from shorter periods. The only randomised data on the question of duration is a very small pilot trial looking at 2 years versus a longer duration and a small number of patients, and overall not a difference. But when they tried to drill down on very small subsets, the high-risk group perhaps seemed to do worse with the shorter duration. The positive trial interrupted adjuvant endocrine therapy, and I'm just showing you here the different types of endocrine therapy. So some patients did receive an aromatase inhibitor and ovarian suppression, and some received a SERM and ovarian suppression. And I'm showing you in the box over there, there's those cohorts and what was their chance of developing a breast cancer event. So there were women who did interrupt ovarian suppression in this trial, but we have 3-year data and we need longer data to understand the long-term implications. So in conclusion, adding ovarian suppression to tamoxifen reduces recurrence if there is residual function and the patient is not at low risk. If we use an aromatase inhibitor as an alternative to tamoxifen, we can further reduce recurrence. The absolute benefit is correlated with your baseline risk, and when the baseline risk is higher, the benefit will be larger. It will also be larger in very young women. Tamoxifen alone is still appropriate for low-risk features. Very young women should be considered for ovarian suppression. The risk of non-adherence is higher in very young women. If the patient doesn't tolerate 5 years, you can give less. You may need to switch to tamoxifen. You might consider interrupting, as in the positive trial. Ovarian suppression with chemo can increase the prospects of future pregnancy. Be careful with the aromatase inhibitor and chemotherapy-induced amenorrhea. And think of this ovarian suppression and ER-negative breast cancer to prevent unnecessary menopause. Thank you.
Our next presenter is Professor Jennifer Schenk, who is an assistant professor of oncology at Johns Hopkins University School of Medicine. Her research includes capturing adverse symptoms of endocrine therapy, identifying tools for early diagnosis of potentially debilitating side effects, understanding health patterns and comorbidities in breast cancer survivor, and exploring strategies to treat obesity. Professor Schenk focuses on personalizing and adapting weight loss intervention in breast cancer survivors, digitalizing provider and patient education, and enhancing quality of life during and after a breast cancer diagnosis. She's also conducting studies to understand and improve body composition in breast cancer survivors, biomarkers that can predict response to lifestyle intervention, and clarify the underlying obesity gene signature that may impact cancer outcome and survivorship. She has very good personal reason for not being able to join us in person, but we are very grateful that she can join online, and she's going to talk about survivorship.
Thank you for that introduction, Dr. Lambertini. I'm grateful for the organizers for this opportunity. I'm now 38 weeks pregnant, so it is a pleasure to give this talk live and remotely. Next slide. My disclosures are as listed. Next slide. As the topic of survivorship is very broad, I've selected just a few hot topics for this educational session. We'll start with a quick overview, followed by a narrow focus on fertility and childbearing, psychosocial health, treatment-related issues including insomnia, weight gain, adherence to endocrine therapy, sexual health, and menopausal symptoms. And lastly, support programs for young adults with breast cancer. Next slide. Next slide. There are unique issues that arise from the treatment of breast cancer in young adults. To optimize survival and quality life, we must incorporate multidisciplinary strategies at diagnosis and in survivorship. Unfortunately, the young population is often underrepresented in trials. Additionally, the selection of endpoints for trials is often determined by pharmaceutical companies, and it may not match the priorities at an individual level. Let's now delve into a few high-priority issues for young adults. Next slide. preservation of oocytes, embryos, or ovarian tissue should be pursued promptly. At diagnosis, education and the development of premature ovarian insufficiency is critical, and the benefits and risks of GnRH agonists should be considered during treatment. Discussing the need for contraception is also important. After treatment, appropriate timing of pregnancy should be addressed, and if endocrine therapy is interrupted, patients should complete treatment after pregnancy. Next slide. Longitudinal fertility discussions are needed. In the Young Women's Breast Cancer Study, 36% of women reported interest in future biologic children within 5 years of diagnosis. And among women who attempted pregnancy, 69% conceived. Those who were 30 and younger, never had a pregnancy before, and not on endocrine therapy were the most likely to become pregnant. Next slide. This international multi-center retrospective cohort study included female participants diagnosed with invasive breast cancer at 40 years or younger between 2000 and 2020, carrying germline pathogenic variants in BRCA1 or 2. The black line in this figure demonstrates the overall cumulative incidence of pregnancy at 10 years was 22%. The median time from diagnosis to conception was 3.5 years. Additionally, at a median follow-up of 7 years, pregnancy did not worsen disease-free survival. In fact, patients with pregnancy had better breast cancer-specific and overall survival. Next slide. In the positive study, a single group trial evaluated breast cancer events after an interruption of 18 to 30 months of endocrine therapy in females aged 42 and younger to attempt pregnancy. The median age was 37, and the majority of participants did have stage 1 or 2 breast cancer. 74% had at least one pregnancy, and 63% had at least one live birth. It was a relief to see that the 3-year incidence of breast cancer events was 8.9% and not significantly different than the 9.2% in the control cohort. Next slide. Our current guidelines recommend a washout of 12 months after the receipt of chemotherapy, 7 months after the completion of trastuzumab, and 3 months after the discontinuation of tamoxifen. We need to keep in mind that more evidence is needed for newer drugs, including immunotherapy and targeted therapies. Next slide. With regards to the drugs with limited data to guide washout recommendations, general guidances are 3 months for CDK4/6 inhibitors, 4 months for pembrolizumab, 5 months for atezolizumab, and 1 month for olaparib. Recommendations for TDM1 and pertuzumab are forthcoming with the MOTHER study. Next slide. Assisted reproductive technologies include ovarian stimulation with hormones for IVF, embryo transfer, and intrauterine insemination. Fertility preservation includes ovarian stimulation with hormones and subsequent cryopreservation of eggs and embryos, GnRH analogs during chemotherapy. Neither fertility preservation nor assisted reproductive technologies have been associated with worse survival. The 5-year disease-specific survival was 96.9% in assisted reproductive technology groups versus 94.1% in those who did not pursue those. In a cohort study of women with BRCA1/2 pathogenic variants, there was no difference in recurrence at 5 years in those having a baby with or without assisted reproductive technology. Fertility preservation is associated with greater incidence of births and use of assisted reproductive technology. The 10-year cumulative incidence of births was 40.7% among fertility preservation group versus just 15.8% among comparators. The 5-year incidence of death was 5.3% versus 11.1% for women with and without fertility preservation. Next slide. In the positive study, fertility preservation and assisted reproductive technology did not increase 3-year risk of recurrence. The figure on the left shows no significant differences in time to first invasive recurrence for those who did and did not receive embryo or oocyte preservation. And the figure on the right shows no significant differences in the same endpoint for those that received ovarian stimulation or not. Next slide. There are concerns regarding the use of biphosphonates in premenopausal women in their fertile years due to the long half-life and ability to cross the placenta. Systematic reviews of use before or during pregnancy do not show significant increases in poor outcomes. However, these are mostly case reports. There are many limitations, including small numbers and lack of use of Zometa. On the other hand, denosumab may have lower long-term risk as it's a monoclonal antibody that is a reversible therapy and it's not incorporated into bone. There is one 12-month randomized controlled trial of denosumab versus placebo in those that are on ovarian function suppression and aromatase inhibitor. This study demonstrated preservation of bone mineral density, bone architecture, and strength. Unfortunately, there are no studies on denosumab and fertility. There are just some case reports on the use of denosumab in pregnancy. Next slide. There are also other family planning options. A traditional surrogate can be used and is both the egg donor and the person who carries the fertilized egg to term and delivers the baby. A gestational surrogate carries a fertilized egg to term and delivers a baby for someone who can't get pregnant. In the United States, there are three main ways to adopt: private domestic adoption, international adoption, and foster adoption. Next slide. Let's move on to psychosocial health. The NCCN Breast Cancer Panel recommends assessing for distress in patients with newly diagnosed breast cancer. The distress thermometer displayed here can be used to evaluate the level of distress a patient has been experiencing over a week. We know that younger patients diagnosed with breast cancer have much higher rates of psychosocial distress than patients diagnosed at older ages. Next slide. The Young Women's Breast Cancer Study evaluated coping strategies at 6 and 18 months after diagnosis and evaluated anxiety 2 years after diagnosis. In the bar chart, the y-axis includes various types of coping strategies, including other individuals, hobbies, work, religion, and lifestyle. Social supports were most commonly provided by a partner and friends. Those with greater reliance from other family at 18 months were less likely to have anxiety at 2 years. And those with greater reliance on alcohol, other drugs, or taking care of others were more likely to have anxiety at 2 years. Next slide. Fear of cancer recurrence is highly prevalent in young adults with breast cancer. At baseline, 65% of women reported that they were moderately or very much concerned about recurrence. This number decreased over time, with 48% reporting that they were very concerned about cancer recurrence at 5 years. Next slide. There is a cognitive existential intervention that may reduce fear of cancer recurrence. In this randomized trial, those in the intervention arm received 6 two-hour weekly sessions with structured topics, such as identifying triggers, inappropriate coping strategies, increasing tolerance for uncertainty, setting realistic goals, and so on. This intervention resulted in a greater reduction in fear of recurrence after treatment and 3 months thereafter compared to the control arm. Next slide. Structured couples therapy can reduce anxiety about oncofertility before treatment. In this study, nearly double the number of women experienced a significant reduction in post-traumatic stress symptoms after the receipt of couples therapy. The therapy also improved stress coping and marital communication for partners, and overall, the therapy improved consultations for fertility preservation and knowledge. Next slide. Now, let's highlight some treatment-related. Next slide. Can we go back one? Insomnia is highly prevalent during chemotherapy. Cognitive behavioral therapy for insomnia comprises sleep restriction, stimulus control, sleep hygiene. This is a standard of care. Bright light therapy is a low-cost treatment for circadian rhythm disruption. In this study, participants receiving chemotherapy were randomized to either 6 weeks of the combination of cognitive behavioral therapy for insomnia and bright light therapy, or treatment as usual plus relaxation audio. After 6 weeks, those receiving the combination treatment had clinically significant reductions in the level of insomnia. Additionally, if you look at the figure on the right, fatigue improved throughout the intervention and even at 3 months follow-up. Next slide. Another issue young adults with breast cancer is physical inactivity and excess weight. In the Young and Strong study, the median BMI of 25.4 fell within the overweight range, and women were randomized to a young women's intervention or a control physical activity intervention. In both groups, both physical activity and BMI increased significantly over time. Interestingly, provider attention to physical activity correlated with level of physical activity at 12 months. Those with provider attention to activity were exercising 100 minutes per week versus 60 minutes per week in those without provider attention. Next slide. In this prospective cohort of women initiating endocrine therapy, we found that weight gain is common, especially for premenopausal women. After 60 months of follow-up, the cumulative incidence of at least 5% weight gain was observed in 67% of premenopausal women. Among premenopausal women, treatment-emergent pain, use of an aromatase inhibitor, mastectomy, and white race were associated with significant weight gain. Next slide. This chart summarizes the most updated evidence-based lifestyle recommendations from the NCCN. All patients should be educated about minimum activity of 150 minutes per week, resistance training, and nutritional guidances. I'd like to highlight that red meat should be limited to 18 ounces per week. Alcohol should be used sparingly, if at all, and up to 3 servings of soy is noted to be beneficial in overall health. Next slide. The breast cancer weight loss trial has randomized over 3,000 patients with breast cancer with a BMI of at least 27 to a weight loss intervention versus control. Those that were randomized to the weight loss intervention lost an average of 4.8% of baseline body weight at 12 months versus a 0.8% weight gain in the control group. The intervention yielded less weight loss in premenopausal women and in those who identified as Black or Hispanic. These findings highlight that tailored weight loss interventions may be needed to augment weight loss in Black and younger patients. Next slide. Another issue in young adults with breast cancer is adherence to endocrine therapy. Discontinuation rates of first prescribed endocrine therapy in premenopausal women was about 35%. Adherence was lower in those that were living alone, unemployed, had a lower stage of cancer, no receipt of chemotherapy, higher comorbidity, and use of chronic non-cancer medication. Ultimately, discontinuation before 5 years was noted in 15% of women, with fatigue and insomnia being common reasons. However, there are some interventions that may help to improve adherence through early detection and management of side effects. Effective and scalable interventions of machine learning models with patient-reported outcomes may help. Support groups, psychologists, and navigators may need to be involved as well. Next slide. Menopausal symptoms are of a major concern to young women with breast cancer. There are now many options for vasomotor symptoms, including pharmacotherapy, cognitive behavioral therapy, and hypnosis. Yoga, acupuncture, and stellate ganglion blocks can also help. Newer drugs like Veozah are being studied in breast cancer patients. Both sexual dysfunction and vaginal dryness require a more structured approach to management. Next slide. As detailed in the ASCO educational book for sexual dysfunction and vaginal dryness, we should first advise patients to eliminate irritants, including parabens and fragrances. Second, we should advise a non-hormonal moisturizer at least 3 times a week. We do need to educate users that oil-based strategies might degrade latex condoms, and that hyaluronic acid can aggravate any burning sensation if a present symptom. Third, a silicone lubricant is actually preferred and more compatible with devices. Fourth, dilator therapy at least 3 times a week for 10 minutes is advised for anyone with dyspareunia or vaginal stenosis. Pelvic physical therapy can also be immensely helpful. Fifth, low-dose vaginal estrogen and DHEA can be used for persistent symptoms despite the above said methods. For those that are on aromatase inhibitors or at very high risk of recurrence, use of just 1 to 3 times per week might be more appropriate. There was a large cohort study recently published that did not show an increase in breast cancer-specific mortality with the use of vaginal estrogens. Lastly, lasers should be avoided until there are placebo-controlled trials demonstrating efficacy. Next slide. With regards to low libido, there are 2 FDA-approved medications in the general population. Addie is used daily at bedtime, and it has a small study of women on endocrine therapy showing improvement in desire, lubrication, and satisfaction after 6 months of daily use. Vyleesi is only used on demand and has not yet been studied in breast cancer survivors. Next slide. There are many more potential toxicities from endocrine therapy and some evidence-based strategies for the management of musculoskeletal symptoms, low bone mass, alopecia, fatigue, insomnia, and ocular issues. Next slide. There are randomized controlled trials providing compelling evidence for interventions. In this figure, the more compelling interventions demonstrating efficacy are denoted by darker shades of color. For example, if you look at the purple section in the bottom right of the figure, cognitive behavioral therapy and exercise can be very effective approaches to fatigue. If you look at the red section at the bottom left of the figure, acupuncture, exercise, and duloxetine can be very effective for musculoskeletal symptoms. We've already touched on sexual dysfunction and the impact of vaginal hormones, and cognitive behavioral therapy has also been found to be very effective. With regards to weight gain, diet, physical exercise, and cognitive behavioral therapy all have strong supporting evidence. And we briefly mentioned hot flashes already and the benefits of cognitive behavioral therapy, pharmacotherapy like gabapentin and pregabalin, progestins, oxybutynin, SSRIs, SNRIs, and clonidine. Next slide. I'd like to spend a few minutes addressing support programs specifically for young adults with breast cancer. Next slide. For most, insurance coverage is a basic necessity. Medicaid expansion under the Affordable Care Act in 2010 was associated with greater receipt of endocrine therapy by 2.4% of individuals. And this expansion was actually associated with reducing treatment delays of 60 days by 1.65% and increasing 2-year survival by 1%. As of today, there are 41 states, including DC, that have adopted Medicaid expansion, but there are still 10 states that have not. This study provided evidence of the benefit in cancer care and outcomes for Medicaid expansion among young adults. Next slide. This is an evaluation of 115 articles on programs specific to young adults with breast cancer in which they identified key components of these types of programs. They included clinical care, supportive care, research, and education. Unfortunately, the major limitation to the establishment of these comprehensive programs for young adults with breast cancer is funding. Next slide. Supportive programs ideally include a very large multidisciplinary team, should involve a social worker to address income loss, return to work, financial support, peer support groups. an oncofertility specialist to address gonatotoxicity and fertility preservation, a menopause specialist to address cancer-related menopausal symptoms, a pelvic floor physical therapist to address bowel, bladder, and sexual function, sexual pain, and return to intimacy, a psychologist to address fear of recurrence, body image concerns, sexuality, and intimacy concerns, and a child life specialist for children and families. Obviously, the major limitation here is resource availability to provide all of these much needed services. Next slide. I'd like to conclude my talk with the following key points. Pregnancy and assisted reproductive technology are not associated with worse survival. There is limited data, however, on new drugs and the impact on fertility. Young adults have high rates of psychosocial distress, and helpful strategies might include cognitive existential interventions and couples therapy. Improving adherence to endocrine therapy may require machine learning models that integrate patient-reported outcomes, and also ensuring that there's access to support groups, psychologists, or navigators for patients. Premenopausal women gain significant weight after diagnosis, are insufficiently active, and have greater difficulty with weight loss despite lifestyle interventions, and targeted approaches are needed in the future. Vaginal lubricants and moisturizers are the primary non-hormonal treatments for sexual dysfunction and vaginal dryness. Newer drugs like Veoza, Addy, or Vyleesi may help with vasomotor symptoms and low libido, but further studies in breast cancer survivors are needed. And lastly, a multidisciplinary supportive program for young adults with breast cancer may help to optimize clinical and supportive care, but are often limited by funding and resource availability. Next slide. Thank you everyone for your attention.
Thank you very much to all the speakers for the excellent presentation. So we have around 20 minutes for questions. There are two microphones in the room, one on the right and one on the left. We have got a lot of questions online, but I wanted to give the opportunity to the people on site to ask questions before asking those of the online audience. Okay. Yeah, please. We cannot hear you, sorry.
Can you hear me?
Yeah, now yes.
Okay. You showed a 3% survival benefit in text and soft for HER2-negative women who got an AI and ovarian suppression as opposed to tamoxifen and ovarian suppression. But what about the HER2-positive subgroup? Didn't it show the opposite? And should we be treating these subgroups differently?
So it's true that the majority of patients in soft and text had estrogen receptor positive HER2 negative tumours, so we have a fairly large data set. There was a minority that had HER2 positive, hormone receptor positive cancers, and because of the era in which the trials were conducted, these trials started randomising at the end of 2003, which was before we had the adjuvant trastuzumab data. So there were patients in the soft and text trials with HER2 positive cancers who did not receive adjuvant HER2 targeted therapy. So it's a relatively smaller cohort, and also not all the patients received trastuzumab. So the HER2 negative cohort were really treated similarly to how we would treat them now, whereas the HER2 positive, there is some variation. Allowing for that, it was not as clear in the HER2 positive cohort, if there was a clear benefit to a specific endocrine therapy. In soft, it looked like perhaps the ovarian suppression and tamoxifen was looking, to be, preferred. But I would say there are caveats with a small sample size. Not everybody got adjuvant trastuzumab, and so I feel those data are less secure, whereas the data really is fairly consistent that if the tumour is HER2 negative, that the best, most intensive endocrine therapy, the one with the aromatase inhibitor and ovarian suppression, looks to reduce recurrence.
Thank you.
Here on the left, Dr. Vogel.
Yes, thank you. Dr. Francis, a wonderful presentation. So you haven't cured everybody. Are there some patients you would want to give endocrine therapy longer? And if there are, what endocrine therapy do you think we should give or we should study? Because I don't think anything clearly works as endocrine therapy after 5 years of an aromatase inhibitor.
So it's true we don't have randomized data for premenopausal women beyond 5 years of ovarian suppression. In the SOFT and TEXT trials, patients were assigned to, if they were assigned to ovarian suppression, it was for a 5-year period, and the trial protocol was actually silent to what endocrine treatment, if any, they received afterwards, and that was varied according to whether they wanted to have a pregnancy, whether they wanted to continue, but the ovarian suppression medication was not provided by the trial after 5 years. I mean, we can probably learn something from the postmenopausal situation, and in the postmenopausal situation, the extension of aromatase inhibitor therapy beyond the 5-year time point certainly reduces contralateral events, locoregional events, perhaps less so for distant recurrence. However, if you look at the patients who were entered into those randomized trials of postmenopausal women looking at extension of aromatase inhibitor beyond the 5-year time point, many of those women had quite low-risk cancers. They were node-negative cancers, a lot of 1 to 3 nodes, and actually not so many that had 4 or more nodes or 10 or more nodes, the subgroups that we really worry about. And, my feeling in my own practice for postmenopausal women is if they have a very heavy nodal burden, I would like to go on longer than 5 years, even if I don't have perfect data. I know the Oxford Overview Group are working on a meta-analysis for the postmenopausal situation, looking at the extension. Premenopausal women have a lot longer to still have an event. Reassuringly, thus far, we aren't seeing problems with mortality, increased mortality from the ovarian suppression itself. But I think, and if a woman is close to the natural age of menopause, I'd be happy with a laparoscopic bilateral oophorectomy and then perhaps a longer aromatase inhibitor. But I think the most complicated group is the group that is very young to start with, and we really don't know how long to keep going. But I think perhaps the message that we see in many trials, if there is a high absolute risk of recurrence, then perhaps that's where you might find any benefit from more intensive therapy of any sort.
Indeed, on this subject, there has been a lot of online questions, both HER2 positive as well as duration beyond 5 years. I see other 2 people standing, and then I'm going to ask a few questions online.
Hi, Melanie Sheen, New Orleans. There is a glaring gap in this discussion, which is in racial and ethnic diversity. Initially presented some data looking at parity and how that may be protective. But we know that high parity in African American women can actually increase their risk of breast cancer in women under 45. So wondering if y'all can comment to that, because I think this definitely needs to be addressed.
No, yes, absolutely. I think that there are many ongoing efforts to fill that gap, meaning to understand breast biology from distinct ancestries. That's where we have to start, right? So what is happening there? I know for a fact that in terms of triple-negative breast cancers, if you compare triple-negative breast cancer from non-Black population and a Black population, you see that there is differential immune infiltration, that you can capture those signals by RNA-seq, by DNA methylation, so the composition of the tumors are different too. Women of African descendancy, they also have a higher mortality of parity alone. We're not even talking about breast cancer. And that has to do with postpartum bleeding problems often, but also high blood pressure that is associated with pregnancy. We cannot address from a basic science perspective. I cannot address the point of ancestry with what we have in our lab right now, but we are moving forward towards into understanding how then we can manipulate those changes in a laboratory setting in terms of high blood pressure, but also change to immunity that you have across ancestries and how that affect cancer risk.
I'd
Yes.
also make, sorry.
Go ahead, Dr. Prince.
Go ahead.
Well, I wanted to add something to that. So this is the first time that we've mentioned barriers outside of access, right, to the care. So that's what I want to address. Dr. Camilla, in your research, you stated that early age of pregnancy decreases roughly 30 to 40%, correct? So were there other barriers that you studied in your research, such as access to care? We talked about ethnicity. We know that that was missed, but demographics for those patients that were involved in your study, and if they impacted those survival rates.
Yes, social determinants,
Yes.
right? So, yeah, so we are putting together U54 that brings together multiple hospital systems in the New York area to come together not only from understanding the cancer as it develops, but also what are all the determinants that are accompanying women that are non-Caucasian and they are presenting with cancer. I know from similar studies, not from the breast, but from the lung, that alterations to cortisol levels was one of the major determinants of lung cancer in the Black population compared to a non-Black population, and that has to do with the stresses that you have throughout your life, just for being and to sound like what you are in life. So I think that we are teaming up with specialists in the area, and that's how much I can address your question. But there is a huge movement, not only bring the biology, but the social aspects of ancestry and that how impact not only the diagnosis, but the care and the outcome.
And the stress levels that are
Yes.
associated with certain ethnicities.
Yes, absolutely.
The other comment I'd make about your question was that triple-negative breast cancer is seen perhaps more frequently in African American populations, and there is data that lactation, breastfeeding, can reduce the risk of triple-negative breast cancer, and there are social determinants in US society that perhaps African American women might be required for financial reasons to return to work sooner. Perhaps America could learn something from some of the Nordic countries or other countries that have more generous maternity leave compensation for women so that they could actually have the opportunity to lactate and not be under such stress to return to work. So I don't know if that's a relevant factor, but it's something to keep in mind.
It's definitely relevant.
Absolutely.
We're going to take one more question here.
Hi, Catherine Harper-Wynne from Kensal Oncology Centre, UK. Just on the point of that group that we probably are looking at, which is the GnRH agonist in the non-ER positives who have completed their family. I mean, a lot of those triple-negative patients will be now having immunotherapy, and just seems unlikely, but is there any data on the use of GnRH agonists with Pembro?
So I don't think GnRH agonist has been tested with Pembro, and this is also one of the concerns about some of the newer drugs in the phase 3 trials, that there actually was not any real information collected on fertility and ovarian function for the young women. So this is a real gap in our knowledge, and there's been an ASCO guideline statement that was published this year or in the past year, that we need to really think about young women when we're developing phase 3 trials in the future. There is a publication by Winship et al. That included Australian authors that looked at a murine model with immunotherapy that suggested perhaps this could be gonatotoxic, but we don't have good data for women. However, we know that endocrinopathies can occur, including the pituitary, thyroid, and adrenal. So it's not impossible that immunotherapy could affect reproductive factors.
And maybe,
Can I just make
Sure,
one
of
point
course.
about the previous comment in terms of ancestry? Melissa Davis will be giving a talk at this meeting, and she has been putting together the most brilliant minds to tackle the problem of ancestry, social determinants of health, and how that changes outcomes of breast. So just go to them.
And maybe going back to the prior question, there has been also a few questions online on this subject. So I don't know if Jennifer, you can hear us. Maybe if you can comment in your clinical practice if you are using a GnRH agonist during not only pembro but also, for example, capecitabine or adjuvant olaparib.
Yeah, unfortunately, I don't think there is any data or any guidances for the use of the GnRH agonist for the adjuvant use of Xeloda or PARP inhibitors. But, you know, we've been looking, I think, through some post-marketing studies in like Monarch E for other targeted therapies in terms of fertility, because those patients were required to use contraception for the entire period of 12 weeks after their last dose. I think that in terms of the other guidances for the immunotherapies that were mentioned, it's just based off of, I think, half-life calculations in terms of fertility, in terms of when it would be safe to pursue, but I don't believe there's any data or guidance about GnRH agonist use with any of those immunotherapies.
And maybe one more question online for you, Jennifer. You have discussed the use of topical estrogens. Can you give some insights on the use of systemic estrogens, if you have safety data, and also in the advanced setting?
Yes, so I would say that the oral estrogens are still contraindicated for our patients, especially those that have had hormone receptor positive breast cancer. I think the most robust cohort studies right now have looked at just purely vaginal estrogen use in terms of whether or not it impacts breast cancer specific mortality. So at this present time, I don't think that there is any reassuring evidence that it would be okay to use oral estrogens in that population.
Okay, thanks. I have a question for Camila. You talk about UTI and breast cancer risk could be related to a microbiome imbalance between gut, bladder, and breast tissue.
Yes, so the question is if whether the presence of a UTI could change the microbiome overall, and that could be increasing the risk of cancer. So there have been studies suggesting that as tissues progress from a normal into a preneoplastic tissue, especially in patients with genetic predisposition to cancer, there are changes to the microbiome of the breast. Through the